Hello again. Again, I have no disclosures. This is going to be sort of a continuation of the first presentation. Again, briefly, some background. Simulation is widely utilized in surgical training and is in fact the most preferred learning method by trainees besides supervised surgery. Has been shown to improve surgical skills, confidence, and even resident surgical performance in the operating room. However, we don't really know how these skills developed in the simulation environment is transferred to the operating room. So we kind of wanted to figure this out. So to investigate this, we first wanted to come up with a way to evaluate resident OR performance. So at our institution, we actually developed this tool called the Surgical Training Assessment Score, or STAT. The items are listed on the right there. It is an online mobile-based evaluation tool that's completed by attending surgeons and also the residents immediately after the case to evaluate the resident's OR performance and provide immediate feedback regarding their technical performance. It has 7 questions total, which are based on the validated OSATs while adding assessment for resident autonomy and case difficulty. And as you can see here, the level of attending participation is divided into 4 different categories. 1 is show and tell, 2 is active help, 3 is passive help, and 4 is supervision only. So using this tool, we wanted to explore the association between the resident performance in a lap chole simulation module and their performance in the OR doing a lap chole. So we hypothesized that residents who had higher simulation scores will perform better in the OR during lap choles. Again, we collected data from the resident who completed the 2-week lap chole simulation module on the simulator, and again, used the pre and post test to evaluate their performances using the goals, OSATs, as well as the lap chole specific assessment form. And this time we included their stat evaluation scores, and we only included those scores that were collected after they had completed the simulation module. For statistical analysis, we use the Spearman correlation coefficients, as well as the multivariable mixed linear regression modeling to control for resident attending, level of attending and participation, complexity of case, and also time from completion of the simulation module. Again, we had 21 residents who were included in the study. Majority of this cohort had at least some experience in performing lap choles. We kind of found some interesting associations between stat scores and demographics. For one, we found that female residents actually scored lower on communication with the team, which I can elaborate on a little bit more. But resident case number greater than 51 to 100 of lap procedures as primary surgeon was associated with higher scores in medical knowledge of case, handling of tissue, time and economy of motion, and as well as overall grade. Similarly, hours spent on the FLS was also associated with higher scores of tissue handling and time and economy of motion, which is, makes sense and very reasonable, given, the more you've done, the more you've practiced, the better you're going to do in the operating room. However, we found something interesting in stats versus looking at the stat score and OSAT. We found that the higher score on overall performance on OSAT was actually associated with worse time and economy of motion on the stat evaluation, meaning they did worse in the operating room. And also higher scores on time and motion on the as well. Yeah, it was also on the pre-test, it was also associated with worse handling of tissue and worse time economy of motion and worse overall grade. So this is kind of surprising to us. And if you recall from my first presentation, from the objective simulator data, we found that they moved less, right? And they had less wasted motion, but overall they moved their instruments slower. So we wonder if, there's this concept of like excessive caution. Are the resident after the simulation module, they're more careful with the dissections, meaning they kind of slow down a little bit, and that could be interpreted by the attending surgeon as being less efficient. Similarly, in terms of the goals, which is again a laparoscopic specific skills assessment, we found higher scores on depth perception was associated with worse tissue handling and medical knowledge of case on the stat evaluations. And lastly, looking at the lap chole specific form, we found higher scores on incision and port placement to be associated with better time and economy of motion, as well as handling of tissue, which again is interesting because you see the sort of the OSAT or this lap chole specific evaluation form on the right. And question item number 1, where incision and port placement, it's literally you're describing patient positioning and describing the placement of the trocars. That's purely a knowledge-based question. However, you can probably assume, a resident who's more knowledgeable about the case overall will be more prepared for the case and be better received by the attending surgeon. Again, our study was limited by the small sample size and the retrospective analysis. And of course, there is evaluator bias from both the simulation evaluations as well as the attending evaluations in the operating room. And lastly, as much as the residents attending have enjoyed using STAT and finding it very helpful, it has not been formally validated. That's kind of a big limitation, and is something we're moving forward to try to validate. So in conclusion, we found both significant direct and inverse relationships between resident simulation performance and their OR performance, particularly in tissue handling and economy of motion, but nothing was very consistent. And this potentially highlights the concept of this excessive caution in the real OR environment, where longer operative time and slower movement, although maybe safer in the hands of an untrained resident or not super well-trained resident yet, can be interpreted as worse time and economy of motion by the attending surgeon. And that we definitely believe further investigations needed to kind of determine the optimal methods to assess resident technical performance in the operating room. Thank you.